Good afternoon, everybody, and welcome to the most exciting session of the World Health Summit. This is a big room, so please come forward. We want to make this a very interactive session. There will be questions, answers, discussions. I hope you don't throw things at the panel, but even for that purpose, you need to come closer. So please come into the first rows, and please see this as a very active panel. It's a big room, as I said, and there are 4 parallel sessions still going on, and that's at the tail end of the summit. So we will not have a full room, but I'd like to welcome those of you to this topic this afternoon. It's about universal coverage and the role of the private sector. My name is Armin Fiedler. I work for the World Bank and the lead advisor for policy and strategy. We are just, as I speak, we will be reorganized again. So we'll be all one happy family of about 250 people working in health as a global health family, a global health network. But again, if you're interested in the peculiarities and specifics of that, I can explain to you afterwards. I'd like to thank, first, before we get started, a number of people who were responsible for helping in organizing this. First, our gracious host, the German Federal Ministry for Economic Cooperation and Development. They actually are hosting us for this session, for this symposium. And I'd like to welcome Mr. Dirk Schatzschneider, who is the Director General in the Ministry for Planning and Communication, who will say a few words of welcome. Director General, please, the floor is yours.
Ja, danke sehr. Okay, that's great. Thank you very much. Yeah, thank you, dear Mr. Fiedler, Excellencies on the panel, ladies and gentlemen, distinguished guests. It's a great pleasure and honor for me to welcome you to this important symposium. We are talking here about nothing less than universal health coverage, and at that occasion, about one of the most relevant issues of Germany's current development politics, the role of the private sector. The Federal Ministry for Economic Cooperation and Development is proud to host this symposium together with the World Bank and the hardship initiative. Hardship stands for Harnessing Non-State Actors for Better Health for the Poor. I would like to thank all our outstanding partners for the very successful cooperation on this event. In 2005, the WHO member states made a commitment to achieve universal health coverage. Since then, the concept has been gaining momentum. This commitment of 2005 was a collective expression of the belief that all people should have access to affordable health services. At a conference in Bonn last month, our colleague David Evans, Director of the Department of Health Systems Financing at WHO, gave a very nice answer to the question, why do we need universal health coverage? He said, because people want it, healthy people earn an income, healthy children learn. I like that answer. However, my version of answering the question, why do we need universal health coverage, would have been simply because health is a basic human right. Ladies and gentlemen, despite impressive achievements in the last few years, many of our partner countries still face enormous challenges. 1.7 billion people worldwide have no access to essential medicines and health services. More than 22 million children worldwide are still not part of vaccination and immunization programs. That is unacceptable for us. I am convinced that we all can take action to move towards universal health coverage. And for me, it is particularly important that we mobilize all available resources for that, both public and private. When we talk about private here, we are not just talking about commercial providers, but about all non-state entities, formal and non-formal, for-profit and not-for-profit alike. That includes, for example, private hospitals, NGOs, churches, healers, midwives, and many, many others. The role of the private health sector in low and middle income countries has been steadily growing in recent decades. In most places, more than 50% of the population turn to private providers when seeking health services. And that is true both for poor and wealthy people. Nonetheless, the role and contribution of the private sector is often overlooked. It is discounted or not taken into consideration by governments. The reasons for that range from an unawareness of private sector potential to lack of capacity for engagement to simple distrust. As a consequence, the private health sector is often poorly integrated into the national system. But the private sector is a large and essential player in the game. We are convinced that we can only move towards universal health coverage if the role of non-state actors is acknowledged and properly addressed. For this reason, German development cooperation is working in several partner countries towards better integration of the private sector. Overall, we spent 700 million euros a year on health. For example, we have substantially increased our efforts to involve the corporate sector in joint development projects. More than 1,500 public-private partnerships have been carried out so far, many of them in the health sector, for example, with the training and education of personnel. In 2010, we created the German Healthcare Partnership as a strategic alliance with German industry. German global players like Siemens and Boehringer Ingelheim are as much a part of it as medium-sized healthcare companies that are often world leaders in their respective fields. We are convinced that governments alone cannot achieve development. It takes the coordinated efforts of all government institutions, private enterprise, civil society, and academia. And there will be no sustainable development worldwide without sustainable economic development. Ladies and gentlemen, dear participants, our department wish you fruitful discussions this afternoon on how to make best use of the potential of the private sector for universal health care. Our slogan in the German Development Cooperation is Future Makers, or Zukunftsentwickler, as you can see on the banner behind me. So I would like to invite you, let's build the future together. Thank you for joining us today, this afternoon, on the conference, and thank you very much for your attention. Thank you.
Thank you very much, Mr. Schatzschneider, representing the Federal Ministry, and thanks again for hosting us for this event. Let me first just provide some definitions, some boundaries of what the discussion this afternoon will be. When we talk about universal coverage, what we mean by that is not only access to services, which is obviously a fundamental part of it. We mean access to quality services, because if you have access to services which might be even more harmful than good, we will not achieve what we want to achieve, namely good health outcomes. But we also, let's think about where we are. We are in Germany, where about 140 years ago, financial protection, the the building blocks of the Bismarckian health system were erected 140 years ago here. So it's about financial protection, making sure that not only the poor have access to coverage and to services, but also that in the process of seeking health, you do not fall into poverty. And anyone who is not very rich, as, for example, the United States could illustrate, if you're not very rich, even if you're middle class, if you're only exposed to out-of-pocket payments, you can slip very easily into poverty. And we have seen this in a number of countries also in the context of the global financial crisis. So, in terms of the definition of universal coverage, what is the private sector? Some people believe when we talk about private sector, it is only about the for-profit sector. We would like, as the hardship partnership indicates, we'd rather have a definition that says non-state actors, because the private sector is the for-profit, the non-for-profit sector, it's civil society organizations, non-governmental organizations, faith-based organizations. They all participate in providing services, providing financing, providing risk pooling at times. So just for the purpose of this discussion, how we see the private sector. Now to the topic. Universal coverage is now something everybody seems to be, it's a very sexy topic all at once. Many of us have worked on universal coverage, we might have called it differently, for many, many decades. I mean, that's what we do in health, whether we are on the financing side or on the provision side or on the public health side. I think it is not that new, but we are glad to see that it has got traction in the international dialogue, that we are thinking about systems and thinking about access, universal access to services and to risk protection, and not only in fighting individual diseases. But I hope that the discussion will further illustrate this point and also highlight some of the tensions. For example, one is universal coverage also only can be a means to an end. The end has to be improved health status. And neither only financial protection nor access to services will yield good health status. There's this whole dimension of public health, the need to regulate the public and the private sector, social determinants of health, and I hope we will have an opportunity also to cover some of these aspects, certainly not exhaustively, but I hope with some of our panelists we'll also focus on this matter. Now, without further ado, let me introduce the illustrious panel here. To my left is Marie-Paule Keeney, who is the Assistant Director General at the World Health Organization. She's responsible for health systems and innovation, so a very appropriate portfolio for this discussion. She has been with WHO for a number of years, but she also has a very distinguished career in the private sector before she came to WHO. So all of our panelists, as you will see, have some linkage between the public sector and the private sector, and I'm glad that Marie-Paule could make it for this session this afternoon. To my right is my colleague Kama Rogo. He's a lead specialist at the World Bank and IFC. It's a joint department for investment climate. He's also the head of the Health in Africa initiative. Prior to that, he also had a distinguished career in the private sector. I mean, not only is he a professor for OBGYN in Nairobi in Kenya, but also he founded a network of, I believe it was at one point the largest network of private providers providing high quality care, particularly for reproductive health for populations in Africa. We have to my extreme left, appropriately, is Eduardo Missoni. And Eduardo, somebody asked me outside, is he from the fashion house in Milan? And I said, well, not that I know. He is, all right. Somehow related. So if you want to have the newest shoes or handbags or dresses, you can actually approach him and after the break, he might give you a special deal.
Not so much.
But for the purpose of this discussion today, he's a professor at Bocconi University, and his department is called the Center for Research on Health and Social Care Management at Bocconi University. That unit is concerned about evaluation of not only health systems, but also performance of both public and private actors. It's an economic department, so it's not a school of public health. And Eduardo has not only a great experience globally, he has worked extensively in Latin America, but also has published widely, most recently on the role of the BRIC countries in leading the charge for universal coverage, but also what I mentioned before, some of these kind of less tangible items of the potential and the need for regulations of other players, private players, which have great influence in health outcomes, particularly for poor people. I then have Ainura Ibrahimova, a colleague with whom I have worked for a long, long time. Ainura was the Deputy Minister of Health of the Republic of Kyrgyzstan, and she was also the Director General of the Health Insurance Fund of Kyrgyzstan. I think she was the first director of the Health Insurance Fund after the Health Insurance Fund was established in Kyrgyzstan. So she has a great experience for setting up this innovative institution in the context of a country which saw at that time rampant private sector activities in the context of a public system, and I hope Ainura will, in her presentation, focus on this. She works now as a consultant for WHO, the World Bank, many other institutions. Has a great wealth of experience. One person whom you don't see up here is my colleague Tom Feeney, who sits down there, who is the rapporteur, and Tom is the program manager of the hardship partnership. And as you can see, maybe you cannot see it, but the hardship partnership is really a growing partnership. Hardship stands for Harnessing Non-State Actors for the Health of the Poor, as the Director General has mentioned. And it's a growing partnership, not only of institutions such as the African Development Bank or the World Bank and IFC, but also countries are members. It's Nigeria, Rwanda, the Public Health Foundation of India. And then we have foundations like the Gates Foundation. We have bilaterals such as USAID and DFID. And of course, we have the three German institutions, the Ministry, GIZ, the German Development Institution, and KfW, the German Development Bank. So I hope I didn't forget anyone. I hope not. If not, people will scream at me. A 1 minute about the rules of the game. So I will give every panelist a space of about 5 minutes for a very quick presentation from the perch of where they stand or sit. And I will also ask them 1 or 2 questions that perhaps in their statement they can explain. Based on what they will say, we'll have a bit of a more interactive discussion among the panel, 1 minute maximum, 1 to 2 minutes maximum. And then we might have, depending on how the discussion evolves, a final statement, 30 seconds, just a takeaway nugget from the members of the panel before we will open up for the floor to either ask the panel questions, and I will be the traffic cop, or you can ask directly a question to an individual panel member by name, and the panel member will then try to answer the question. And Tom is already taking copious notes, I see, and he will give us a 5-minute summary, kind of takeaway message of the session that we have had. The first one that I will ask is Marie-Paul. Marie-Paul represents the World Health Organization, but she also, as I mentioned before, she has experience in the private sector and knows the rules of the game of the private sector. And so I'm wondering, from your perspective, I mean, it seems to me when you just look at what is said about WHO, for some observers, WHO is too negative with regard to the private sector. There's tensions there. On the other hand, some argue it's too close, too cozy to the private sector, in the context of vaccines, and there was the debate about the avian flu and so on and so forth. Now, as the normative global health agency, how do you reconcile this? How do you straddle these tensions that on one hand you argue public-private partnerships are necessary and partnerships with WHO are necessary. On the other hand, you can't come too close because there will be otherwise critics that argue you're too close. So how do you reconcile this with the mandate that you have?
Thanks a lot. I'm very happy to have the opportunity to kick this debate with you today, and I thank the German ministry as well as Armin for having invited me. Indeed, I have two credentials to be here to talk to you about this. First, I'm part now, and for the last 10 years or so, as a very public intergovernmental organization, the World Health Organization, in charge of health systems and promotion of universal health coverage. And I have worked for nearly 20 years in the pharmaceutical for-profit industry before that. So this is why Armin thought that I must have some ideas about how it works together. So clearly now, as the concept of universal health coverage is getting increased endorsement across member states, academia, and the international community, it is becoming obvious to all of us that both the public and the private sector need to act together to realize the vision of universal health coverage. So why is that? Why can't the public sector do it on its own? Well, it is clear that the private sector in health services have comparative advantage in many areas. They are better at generating resources, ability also to drive potential better health with research and development of new drugs and technologies, the freedom also to experiment with new incentive mechanisms and business operations skills, and to generate evidence and tool for gaining efficiency are all areas that the private sector leadership can serve as benchmark for the public sector. But there is another reason why the private sector can be an engine in achieving universal health coverage, and this is primarily because of its reach. In many Asian and African countries, according to data from the bank, between 30 to 80% of primary care is provided currently by the private sector, and is nearly half of hospital services. In many Eastern Mediterranean countries, the private health sector has rapidly grown in the past 2 decades. But unfortunately, due to lack of government regulation, some problems have emerged. Here in Europe and also in the America region, the size of the private sector is roughly speaking stable in some countries, but increasing in many of the rapidly changing economies. For instance, over the past 10 years, there have been a slight increase in private expenditure in France and Germany, and a slight decrease in the UK. The point here is twofold. First, the private sector is serving quite a large segment of the population, and at the same time, we have currently limited intelligence work about the private sector and how it operates. Now, coming really to see how we can address the conundrum that Armin just mentioned. How can we work more with the private sector, being engaged in public-private partnership, and at the same time avoid what some countries may see as a conflict of interest? Well, you may know or not that the 23rd World Health Assembly has passed a resolution so very recently on strengthening the capacity of governments to constructively engage the private sector in providing essential healthcare services. So this is very important because the nations together are seeing the need to engage in the private sector. But they also say that we should help the government to engage constructively, which means not in a sort of Wild West environment. This is towards a constructive discussion. So, following the adoption of this resolution, WHO is to advise countries on appropriate approaches to engage the private sector by convening policy dialogues and by conducting research to develop a regulatory framework for this engagement. We are thus in a process now of identifying legal, regulatory, financial, and ethical approaches to harness the private health sector to improve access to quality services. We are, for example, engaged in public-private partnership for the control of tuberculosis, malaria, and HIV. We are calling on private pharmaceutical industry to conduct research and produce cheaper drugs for neglected tropical diseases and other infectious diseases where there is less profit margin for the private sector. We are also engaging now with the food industry for protecting the general public while striving to avoid issues of conflict of interest. So there are many activities on many fronts, and there are good progress and some initial good result. Now, in order to achieve universal health coverage within WHO, as we are getting organized and we are in active discussion, as I just said, for the formulation of promising approaches, intervention, and pathway towards universal health coverage that are tailored to country situation, I would argue that the private sector needs to be part of a social discussion, but that this part needs to be under the regulation of the public sector. Here, I would like to invite you all to join us to develop ideas and thinking for a more feasible and productive private sector, health sector participation towards a progressive realization of universal health coverage. Thanks.
Thanks, Marie-Paul. A few years back, I was in London. There was the presentation of Michael Marmot's book on social determinants for health, and I was representing the World Bank group at the time. When we say group, it means World Bank and IFC. And there were people in the audience who gave me a real hard time because they were saying, you guys, you just raised $1 billion for the private sector in Africa. This is going to be money for the rich, and the poor will fall through the cracks. Now here we have my colleague Kama, who heads up this program, Health in Africa. Now, is that criticism correct? What happened in the meantime? And are we truly on the right track to harness the private sector for the health of the poor, in particular from your experience in Africa?
Thank you very much, Amin. And thank you for the invitation to be here. I'll answer your question by going through 12 hours of the life of an African woman yesterday in Kampala who was 38 weeks pregnant and needed to go and see her prenatal clinic. She woke up at 6 a.m. because she had to be there early and queue. She took transport, a motorcycle, to that clinic. She was not seen until 11 a.m. by the nurse midwife. The nurse midwife did not find she was in labor, but thought that she had urinary tract infection. Gave her a piece of paper to have her urine tested, but in that public clinic that she'd gone to, the lab wasn't working. She therefore went to a private laboratory, again took another motorcycle, had the test done, and she brought it back to this midwife in the public clinic. The midwife saw that there was evidence of infection and gave a prescription for some antibiotics. That antibiotic was not available in that public clinic, so this nurse once more took a private motorcycle to go to a private pharmacy where she got antibiotics. She arrived home at 6 p.m. to make food for her kids. At 8 p.m., she had more pain, and this time she thought she was in labor. There was no ambulance to take her, so she called a local taxi, whom she paid to take her to the nearest public delivery place. But on her way there, the membranes ruptured, and she was almost delivering. So this taxi detoured into the nearest private facility that is there, and that is where she delivered. That is why we are doing what we are doing. Ask this woman if what we are doing is right, and the answer will be very, very different from that of any academic. Who took her to where she was, where she eventually delivered? All the transport was private. Yes, the country has ambulance service, but you can't get it. Who did the laboratory test? It was done in a private laboratory. The public one wasn't functioning. Where did she get her medicine? From a private pharmacist who imported it from India. Was it good medicine or was it counterfeit? We are not sure. Eventually she delivered. If we were to look at the statistics 2 years later, who will we say saved her life? Did she deliver in a public or a private institution? The question is, does it really matter to this woman where she delivered? They just want to remain alive. And what we found in our studies before we went to North Africa is that this is the intertwined architecture which our people live through for them to be able to survive a pregnancy, for them to be able to survive childhood, for them to be able to survive any infectious disease. It is an intertwined public-private relationship that exists there. The problem is that we have all refused to recognize this. We've even fought it, to the point that in the work that we're doing in Africa, we have found that there are 3 areas that we have to address to make this work for this woman, because she doesn't have to negotiate an intertwined architecture all the time. Number 1, there is very, very poor dialogue between public and the private sector. And that dialogue has to be set up. We have to support it. It has to work. They are more like Tom and Jerry, public and private, chasing each other, blaming each other within the same space. The sufferer is that particular woman. 2 is that the policy and regulations are just not it. They were never meant to allow this interaction, that learned and productive interaction between public and the private to work. Nobody's regulating. We talk quality, but quality without clear regulation just doesn't work. And 3, there is problems with access to finance, both on the supply side and also on the side of the patients themselves. So the work that we are doing in the region, which every African country is now supporting us on and paying for, is number 1, help create an enabling environment for private sector, responsible private sector, to grow and participate in saving the lives of women and children. So that dialogue process has to be established. 2, look at our policies again. A lot of our African countries have policies and rules and regulations that were inherited from the colonial years. Nobody has ever looked at them. They are not relevant anymore. Change them so that they serve that particular woman. And most important, let us look at how we make it possible for these people to pay for the service, whether it's the public or the private sector. That is where finance comes in. So my summary is that we are following the footsteps of this woman, and we are saying that without effective public and private partnership, without encouraging the private sector to invest more and be more responsible, the dream of MDGs, the dream of universal care just won't reach us fast enough in Africa.
Thank you very much, Kama. Those of you who subscribe to The Economist or just picked up this week's copy, there was an article in there that there's currently a law being discussed in the Mexican Congress. And huge numbers of lobbyists are trying to influence members of Congress. And it is about the regulation of the sugar and beverage industry. Mexican Congress wants to regulate the size of sugary drinks which are sold to the population, taking into account that Mexico currently has, I believe it's the highest prevalence of childhood obesity in the world. And of course, it's not a secret, it's also have the highest per capita consumption of soft drinks. Now, what has this to do with universal coverage? In the lead up to this discussion, it was actually Eduardo who said, many times we're only talking about the supply and demand for services, the financing, the insurance, the risk pooling, but there's another world out there on universal coverage, which is how do we regulate and how do we influence these other determinants of health, because universal coverage or service is only one element at times when it's too late. So Eduardo, I know that you have thought about this matter and published about this matter. Why don't you help us to better understand the dilemma that we're in?
Yes, again, thank you very much for inviting me here, having me here. And in fact, we always look or think at universal health coverage from the side of the delivery of services. and how we face or respond to diseases, what drug, if we have or not drugs, if we have or not staff, if the quality of this stuff. And we forget the other side. I mean, to ensure universal health coverage means that we are able to deal with all the diseases and with all the conditions for all the population. What if the number of diseases increase? Obesity, hypertension, diabetes, cardiovascular diseases are no more only the diseases of the rich. They are increasingly part of a double burden of the poorest populations in the world, who still have, by the way, malaria, AIDS, tuberculosis, diarrhea, pneumonia, and so on and so forth. So they have a double burden. And where does this increase and this double burden come from? You just quoted an example for Mexico. I mean, we have industries, and when we say the private sector or the non-state actors, we are including them transnational corporation, obviously. We don't only, thanks God, we don't only have that private sector. We also have lots of organizations that provide services, that are engaged in changing the system, that are advocating for better health in the different areas. But we have those transnational corporations which invest in increasing our consumption of harmful products. Beverages, junk food are just examples, but I could add a number of pesticides, I could add how the hazardous waste is managed, and many others. So it is very difficult to be able to provide universal health coverage if on the other side we are allowing that the burden of disease is constantly increasing just because profit and margins, are allowed to increase because we have to respond just to the need of the market for more economic growth and more profit, because this is the way society works. We are seen as consumers rather than as citizens, as people who have a right to health. So I think very strongly that regulation, and it has been mentioned, at different levels should come in, and this should be at global, national, and subnational level where this is the case. But let me also say that industry comes not only through these areas external to the health sector. There are also intervention inside the health sector that health sector industry pushes for more consumption. Undoubtedly, margin and profit is vital for pharma industry, so there is a strong, aggressive marketing for buying drugs. You go in any street in Africa, in Latin America, in Asia, and you will see how much there is promotion for buying drugs. Sometimes basic drugs, sometimes other kind, or diagnostic tests and services. So there is a strong propaganda to consume more medical services. Instead, we have to work on how to reduce the consumption of medical services. There are aspects in industry strategies like disease mongering, which is creating the idea of a disease in physiologic conditions in order to sell more drugs. There is pushing for technical solution. We think if we pass the idea that health comes from drugs, that comes from vaccines, that comes from technological devices or technological silver bullets, we are biasing the understanding of the causes of health. That's why we say we have to act on social determinants, and there is a regulation which should come there. Let me add, because regulation, as has been said before, is also related to services. Now, in most poor countries, and my experience is honestly limited only to Latin America and wide parts of Africa, the private sector means non-profits, profit, but mainly non-profit, mainly religious orders in Africa. Churches are providing health services. But even there, they concentrate, we have heard it before, on secondary and tertiary care, on hospitals. They forget that their principal action in reducing disease and providing universal health coverage would be just providing water, food, shelter, education, and other fundamental social rights. So it is very important that we try to bring in that private, if you want, public interest oriented private sector into the planning of the services in a vision of a national local health system in a way that everything is coordinated. We rarely see, for example, private sector, including big companies with their health services, we rarely see them involved, for example, in sector-wide approaches, where other donors, other international actors do sit around the table with the government in trying to planning health. So again, I would highlight the need for regulation, both at the global level, acting on social determinants, as you mentioned before, but also at national level in order to ensure that health is provided under the strong control and promotion of national authorities.
Thank you, Eduardo. Now, many of you know there is a heated debate and lots of meetings happening with regard to the post-2015 world, what comes after the Millennium Development Goals. And it seems that there is a consensus that in some way, shape, or form, universal coverage should be there. Now, one of the concerns, anyone like myself and Ainura and others who have worked in Eastern Europe and the countries of the former Soviet Union, you can have universal coverage, including guaranteed in the Constitution. But at the point of service, there is no universal coverage because, what is supposed to be universal access isn't there. You have to pay. You have to bring the bed linen, the syringes. You have to buy the drugs. You have to bribe the doctor and the nurse. This were at least the results, the issues on the ground that Ainura was facing when she set up the health insurance fund in Kyrgyzstan and tried to establish a mechanism where there was true universal coverage, so people had clear rules of the game, how they can access the health service and have some form of risk protection. Now, I'm wondering, Ainura, what your experience was in this. I mean, has this been sustainable? Because this is a unregulated gray economy, under-the-table payments. It wasn't an official private sector. It was very much an unofficial private sector, but yet a private sector. These were private actions. Money was flowing into private pockets, and certainly it was a huge obstacle for universal coverage. I'm wondering how you did it and how it was sustained.
Thank you. Yes, actually Kyrgyzstan, this is former Soviet Union country, which inherited Soviet Simashka system, guaranteed access to healthcare to everyone for free. And actually, I think that before Soviet Union was collapsed, actually Kyrgyzstan and other countries somehow managed such a system. But after Soviet Union collapsed, Kyrgyzstan faced such a great problem and realized that it cannot afford such a system with bulky infrastructure, with hospital-dominated medical services, no primary health, no family medicine, and very low level of primary health care. And the financial mechanisms was, just aimed to pay for this infrastructure, but not for the results, actually. And the Ministry of Health realized that it cannot afford such system and started reform in early 90s. And this reform was aimed to reorganize the health system from public health system funded by government free for population to integrative complex health system where public and private medical facilities coexist. Government guarantees defined set of medical services which called state guaranteed benefit package. And the official co-payment has been introduced to substitute huge amount of informal out-of-pocket payment which our population paid everywhere, and without this payment, it was impossible or very hard to get medical services. It was such a funny story when in early 90s, our Minister of Health, I think that he was the only one person who believes that it's still free of charge when he asked, why are you asking me for, when I am or my relatives going to medical facilities, they get everything for free. And it was such funny, and we still, remember that Minister of Health. And because others, you understand, paying for everything themselves from their pocket. So 5 minutes, it's really just very short time, but what the Ministry of Health and government managed to do with that health system. First, state guaranteed benefit package has been defined, and together with state guaranteed package official co-payment, the financial mechanisms were changed, and new financial system, which called single payer system, has been built, and all actually public resources, budget, and mandatory health insurance funds being allocated in the mandatory health insurance fund, who administers all of these resources on behalf of the population. Mandatory health insurance fund concludes contracts with all facilities, public and private, to deliver health services, and people who is not eligible for some benefits actually must pay official level of co-payment. And these reforms bring just significant results when the level of non-official payment of population reduced rapidly. And it still exists, unfortunately, because government is not able to provide full funding of state guaranteed benefit package, and it's estimated that coverage of this about 70%, so 30% it's still underfunded, and it means that people still paying for their services, but the level much less than it been before. And the challenges for the government now is to guarantee the full funding of state guaranteed benefit package. And this is one challenge. Another challenge to change mechanisms for fund paying for medical high technology, because this is out of benefit package, and people still paying a lot of money for, unfortunately, for high medical services if they need it. Thank you.
Thank you very much, Anura. We come to our quick second round now, and based on some of the questions that will be based on what I have heard in this first round. Now, there seems to be consensus that in terms of health provision, there is already public and private, whether we like it or not. There is a very much of a mixed system already in place. If you think about most countries of Africa, more than 50% is private delivery of services. We just the hardship meeting was recently in India, where we were told that 87% of services are being delivered by private means. Kama, you mentioned that it doesn't matter in the end. I mean, for the patient, does it matter? But what about health financing and insurance? I remember one of my professors, Bill Shaw, he said, health is a non-insurable good. Now, what's your sense? And I would like also Marie-Paul from WHO's perspective. Are you advising country to have a mixed public-private health financing system? What's your take? I mean, is this fair game, or are you advising based on the evidence it should only be public, or it can be a mix, or what's the context there? Kama.
Thank you. I think that some of my colleagues here have already reinforced some of the points that I was trying to bring out, including the area of health financing. First of all, the dialogue process. What we are doing in Africa is creating that dialogue platform for the private sector to be an equal participant in the strategic setting for the country. It's only when they're part of that you can bring them in to do the things you're saying they're not doing right now. They're ready to do it, and they're doing it. And we have data that is confirming that, even on the public health side. If you look at family planning, for example, in Africa, most of the family planning in Africa is provided by non-state actors. They have started it, and they're expanding it. The family planning associations and so on, those are not state actors. You go into immunization, and we have the data there. Now, when it comes to the area of policy and dialogue, that one we agree to. That is absolutely important, and the role of government in leading that, but working together with the private sector to get the right policies and adjust the regulations. In financing, 3 areas are coming up in the African continent. Number one, 2 years ago, the AU, with the African presidents, mandated that in the next 10 years, every African country must start a social health insurance scheme. It's a big ask, it's a big challenge, but it's one that we have accepted in Africa as the only way.
A public forward. Or private, or is it, they don't say?
No, they leave it for the country to work out what works.
Understood.
Right now we're working on nearly 15 countries, and in all of them, there seems to be I think that there's some consensus that the public must lead, but the private sector has a role to play in that too. How you balance that will vary from country to country. If we have time, I will be able to go into that. Secondly, there is the issue of access to finance for private investment. Because it's not enough to have insurance or insured people when you don't have the facilities which they're going to be treated in. And one of the biggest problems in Africa for private investment is access to capital. We come from countries where the interest rates is 30% per annum. And you just cannot run a business that serves the poor under those circumstances. So mechanisms are coming up for some kind of concessional financing that allows entrepreneurs to be able to get money at a rate that makes it possible to invest within the areas in which they are. And there's good examples of that. USAID, for example, a year ago, we worked together in them creating a concessional financing vehicle in one of the commercial banks in Uganda. They put in $5 million for small-time providers to be able to borrow at concessional rates. Within 6 months, that money was gone, and they're now building into the second one. So this is an area in which there is definite movement forward, and it is where the future lies. Supply-side financing on its own just won't do it.
Thanks, Kama. Just last week, or 10 days ago, we were in Washington. We have a so-called consultative group with the civil society organizations, and they presented to us a paper saying we should stand for public insurance only. Are they right or wrong?
Well, I don't think that there's a need to be prescriptive, and the private insurance can have a role to play. But there are some boundaries. So the system has to be pro-poor. It cannot be that you have private insurance that take only the rich and healthy and that leave the other side and give to the governments the responsibility to pay for all of these people. There needs to be a risk sharing. So yes, indeed, you have to have insurance which need to accept the ones who are healthy and the ones who are less healthy. And yes, the ones who are healthy and who are bachelors, instead of having a big family, have to pay more for the others to get access to care. So the basis should be equity, should be promotion of health, and not only medicalization of health. And therefore, the private sector can have a role, but under, as I said before, regulation and strict regulation of a public sector.
So no ideological position one way or the other?
Except for saying that it should be under the regulation of a public sector.
Regulated, okay. Now, Eduardo, if I may come back to one important thing that you mentioned. You said we need to transcend the focus on the diseases, because, I mean, it's a larger challenge out there. Now, what would be your advice to the German ministry who is represented here today? Like many other governments, they just allocated gazillions for the Global Fund, for Gavi, from some of the international disease financing organizations. Now, are they wrong? Is this the right policy, or do they need to look beyond that? What would be your advice if you were hired as an advisor to the German government, for example?
I'm not the only one to say that they are wrong. Yes, I believe that pouring money in, not because they are global public-private, but because they are autonomous initiatives, autonomously administered, very often fragmenting national systems and acting vertically and separately from the rest, it's wrong to put money in these initiatives. On top of this, I mean, they focus very much on disease, and therefore focus on the medicalization of the answer, and this brings us far away from the needed answer that people really have as problems, the real everyday problem. In fact, I don't love very much the idea of universal health coverage. I'm kind of maybe a little oldish, but I prefer health for all. Is the idea that focusing on health, which includes obviously care, but starts from primary health care, starts from the very needs of the people who are most in need. And again, this is water, this is food, this is shelter, this is education, this is immediate response to most common needs. And then this is also the first element of a full-blown health system, and therefore a step into secondary and tertiary care. But I'm very much afraid of big investment put in hospitals when we have not solved the access to the basic needs of the people. So if you want, we should go back to those that were the strategies at the end of the 70s and beginning of the 80s.
But isn't it, I think, the example that Kama pointed out, if you exacerbate this a little bit further, right? Isn't it, there was an argument at one point that primary health care needs, actually even the poor can afford an aspirin or an ibuprofen. They might not be able to afford a cholecystectomy, or they're not able to afford an institutional delivery, or they might not be able to afford if their child needs an appendectomy. So for that you need a hospital, or at least a semblance of a hospital, right? So are we not barking up the wrong tree to promote primary health care when in fact people die because they have no access to hospitals?
People die because they have no food.
Right.
People die of dehydration because the mother has not been educated to use water, salt, and sugar to rehydrate in time the child, which will die by dehydration. So, I mean, we have, as public health people, or people who have take really with passion the idea of health for all, we have to be able to have the courage to establish priorities and see what is the best use of the money that we can do, and possibly for most of the people. We have to look into not survival, we have to look into life of the people. And this is the issue. So it's a question of priorities. I'm not saying we do not need hospitals, but we need to establish priorities and being able to devote much more investments on the basic needs in order that people can have opportunities to live. See? But if you don't put money into education, if you don't put money into basic services, they will never access any way to a hospital. Or they will go there only to die because they don't even have a road.
Point well taken. Ainura, you're not in government anymore formally, but you know the government very well from different angles and different perspectives. In a country such as Kyrgyzstan, which is still a relatively low-income country, but with an aspiration to become a middle-income country, you have institutions in place, you have come a long way. What is the government's, or what should be the government's vision in terms of giving the private sector an appropriate role, namely in terms of, I mean, you mentioned the risk pooling, contracting out to the private sector, both ancillary services, maybe some part of even clinical services, imaging, laboratory, what have you. Maybe even on the health financing side, starting with supplementary insurance. Is there a vision? Is there a roadmap? Or are we having so many problems with the current system that's even asked too much? And moreover, if you could, the point that again, Eduardo made, is there any understanding of parliamentarians, let's say if this were Kyrgyzstan, the challenge that I pointed out in Mexico, that you have the need to regulate some of the non-health industries because it is seen that they have an impact on health status of the population. From the perspective of a country such as Kyrgyzstan, how does this come together?
Thank you. Okay. I think that our government recognized the importance of private sector more and more. And actually, previous government, not who acting now, but previous government just was very, very, leading by young prime minister. And he was very insistent to increase the private sector level and its participation, maybe too much sometimes. But just the government vision towards, and it's actually in the new dental program and in other programs which now adopted by the government, that the level and participation of private sector should increase. And a good example for this is pharmaceutical sector. Because in our country, pharmaceutical sector was privatized by 100%, I would say, but they participated in the state programs, outpatient drug programs, providing drugs for participation in the, through whole country. And they now believe that some services like laundry or just preparation of food could be transformed to the private facilities, and they are working. They call this as a private-public partnership, and they are working in this direction. And another direction, they are working to change financial mechanisms to pay for private facilities for providing high specialized quality care, because unfortunately it's still not in place. So this is the direction.
What about taxation of tobacco, looking at, I don't know whether the issue is of any kind of the sugar industry, etc. I do not know. But let's start with tobacco.
Yes. Unfortunately, lobby on tobacco in my country just very, very big. And just very recently, Ministry of Health managed to pass through Parliament a new law on this, increasing the access taxes. Yes, and this
excess
is only yes.
Yeah, excise tax. Great. Well, thank you very much. We give now the panel opportunity for a parting shot. Any take-home messages for all of us from what you have heard, based on the discussion, based on the perch that each one of the panel members sits? Marie-Paule, I start with you, just very briefly.
I think that to summarize, the private sector has a role to play, but it's the responsibility of governments to keep their population healthy, both through medical intervention and non-medical intervention, and therefore the private sector should be regulated and under the control of the public sector.
Tama.
I think that in this debate, it's important for us to distinguish what's within our sector and what we can do within the sector, and what is intersectoral, and therefore outside of our sector, but we must look at that. And I think that one is coming up on this debate. Secondly, let us also look, especially for me coming from Africa, one of the biggest success in disease eradication has been the river blindness program, onchocerciasis. And it's a very, very good example of how the public and the private can join hands to go into a disease that not only affects people who are rich, but the poorest in some of the most difficult areas to reach. If we take that as an entry point and we think outside the box, then we can see lots of opportunities out there for us to be able to harness the resources that are out there. The key thing is you have resources on the public and the private sector. We have to bring them together to work for the health of our people. And it only works if we recognize that the private sector exists, is growing, and has that ability to bring in efficiencies and additional resources into this very, very important sector.
Thank you. Eduardo.
First of all, let me acknowledge private sector is a very diverse sector. I don't like the idea of non-state actors bringing all actors together because they have different roles. I totally subscribe the idea that both governments at national level and intergovernmental organizations, i.e. the World Health Organization, have to regulate whatever is health related, and therefore they have to play a strong role also in non-health sector fora. And to do this and to have more strength, national governments and intergovernmental organizations, i.e. the World Health Organization, have to be able to ally, have to search for alliance with civil society, not uncivil society, with public interest NGOs, not business interest NGOs. They have to be able to differentiate between that private sector which is genuinely looking for health for all and for the public good, and differentiating those who are commercial actors who look for their private interest in the sense of growing their wealth, and obviously considering them too, but not making them part of the strategy setting. The strategy setting is a public responsibility at global, national, and local level.
Ainura, your parting shot.
I think that it's actually government function to understand and to maybe even try to understand the nature of each of the stakeholders, of each participants, and trying to involve all of these participants in the, this health system, trying to understand the niche maybe for each of these participants. Because I don't think that private sector itself, just able to do it. And we have to understand that, yes, private sector in that definition you give, this really very, very big and diverse, and Ministry of Health can do it. And I think that that is why actually in our law, the health system identified as a complex and integrated system, meaning a lot of different actually participants in the system, but having their own niche. And another important message, I think, that the government should, actually for government doesn't matter what kind of ownership the facility has. They have to pay for the services if the facility provided the services to their population, government actually, or nation. And I think that changing financial mechanisms, this is extremely important in this matter. Thank you.
Very good. Now it's the audience's time. Please feel free to ask a question to the panel or ask a question to a specific panel member. Please be so kind to identify yourself, approach a microphone, just say who you are, say if you want to address this as a general question, and then I will try to be a little bit a traffic cop. If you have a particular panel member in mind, you can address the panel member directly. Yes, sir.
Okay, hello. Thank you very much for this very interesting discussion. My name is Jonas Albert, and I'm a student at the Management Center in Innsbruck, Austria. My question goes to all panel members, because in some regard you had some kind of the same standpoint on one thing, and that is there should be some kind of like public governance always involved, especially concerning the provider of a good of healthcare in general. Does that really matter? I mean, isn't it really actually just about we would like to define how a market should work, for example, the insurance market, and if the public, if a private or completely privatized market is working perfectly fine and in our standards, then everything is nice. So and if we have to regulate it, or if we have to bring public entities in it, then so we should do that. Isn't it more about to have or to know what kind of market we would like to have, or how we would like it to intend to work? And if it's a national market, which a single governmental entity could probably quite easily regulate and or control, or if you have like the market for pharmaceuticals, an international market where control is actually quite more difficult to achieve. What do you think about that? Does it really matter, public versus private, private and public?
That's a very, for me, a position which I have heard before, again, working in a number of countries which have seen great success in privatizing certain industries. I remember having discussions with ministers of finance where they were saying, well, we just privatized the telecom market. It works much better before, after than before. So let's do the same with health, right? Is that a fair assertion? Anyone from the panel?
No, it's not the same. It's not the same at all, because health is not a marketable good. Health should be a right to everybody. So the regulation, if a mobile phone price is increasing too much, then at the beginning it will be lower, then increasing progressively, then the people will stop buying mobile telephones. But if the health become more expensive, then there's no way people can stop needing health. So this is not a good, health is not a good like all the other goods which can be left to a simply a market where profit-making is the main stance and the main goal of a business.
What about you, Kamet? Opening the market, see how it goes, and then only correct if there are imbalances? Or is this too dangerous of a proposition?
I think that if you're working with government and the private sector in the countries that I do, you'd pause a little bit and think a little bit more about that question. What we are talking about here is the right to health care. We are talking about equity. Who is supposed to ensure that that right is actually obtained? It can't be the market. It can't be the private company. The government has a responsibility there because it is the constitution of that country. However, one has also got to understand that the way in which you regulate has to change. We've gone through the situation where governments come and put a regulation that is more harmful to the people than would be the case. So the dialogue that's needed in a country for them to come up with the right regulations is important. And it is happening now even in Africa, and it's creating what we want. Thirdly, let us ask ourselves the question, how do you obtain quality in health services? Is it just regulation? Because we know that they are there in a lot of our countries, but they is not imposed. Is it you leave it to the professionals to self-regulate? Does that one happen? Does it depend on the ability of the consumer to choose? In our countries where the consumers are less well informed, there's risk there. So there's a lot of things in the question that you ask that in the circumstances in which you work have to be taken into account. It's not an easy one. But the final responsibility for the right to health care must be that government of that country. How it delegates must be towards that right to health care and nothing else.
Anyone else from the panel? I mean, Ainura, isn't it also difficult to find the capacity to regulate? I mean, that sounds so easy to regulate, but I mean, to be a regulator is also quite a difficult challenge, right?
Yeah, it's a difficult. Actual question is very provocative, I would say. And I think that such kind of debates you can hear in many times, including our government. Because in our government, just our previous government, they tried to declare that health and medical services. This is like services, and they trying to change the mechanisms in healthcare to pure market. But it was impossible, and actually, I mean, I didn't want to describe this, but I just now need to do it. So it was a huge battle in my country about this, and actually, I think that we won this battle, and we would say that health. This is not, just subject to be trade, to be purchased, and including, by the way, pharmaceuticals. So this is another battle we are having in our country, trying to develop new pharmaceutical policy, drug policy, and this is another battle now we experience in our country. Okay, coming back to this, I think that this thesis that health, this is not health services. Health, this is not subject for the market. It's now thesis in our new government, and they understand it. So nothing changed, and actually we were happy that nothing changed because we managed to pass through legislation all of our main topics or main theses maybe, and that is why that previous government, they couldn't change our health services. Now, I think that what is important in this battle, this is providers. Actually, for providers, it could be market, and the topic and the issue is who is paying and how we regulating quality of care. And quality of care, actually, these regulators, this is Ministry of Health with all of the normatives, which providers must actually execute, I think.
Now, Eduardo, what I heard from you, you would even go beyond the in-country regulation, right? I mean, from your perspective, you want to increase global regulation, including of transnational, multinational companies. So you would be against a free global market, even of tradable goods. I mean, Ainura mentioned health is not a commodity, right? It's not like something that you buy and sell. But others would argue, sure, Coca-Cola is, or Fanta, or whatever, tobacco. It's the consumer's choice. And I remember well, there was in the European Health Forum in Gastein, there was some lady in the audience who was saying, you health guys, you want to regulate everything, right? It was first this and that and tobacco, and now you go after sugar, and soon it will be coffee and cookies and ice cream. So where does it end?
If health is a public good, or if you want, health is a fundamental human right, and therefore should be defended by all of us, if we believe this, then obviously we need public authorities to take a stand on these things. If there are products which are harmful to health, we have to limit them or to avoid them, simply not produce them. And there is the responsibility of public authorities to care for the public health, to care for public good, to care for public rights. So we cannot live, and health, I believe, is not one of those things that are marketable. By the way, also to respond to our friend, there are other things which are not marketable. For example, the country's security. Would you privatize defense and allow everybody to buy a tank as they like and manage autonomously? You wouldn't, because you believe that there is a public responsibility for the defense of ensuring the security of the country. So if you believe that health is a fundamental human right, you would ensure that your authorities control health. Now, you ask me globally. Yes, why? Because there are countries which have strong institutions and have the strength to organize their own regulation and go their way. But there are weaker countries with weaker institutions that are not able to resist lobbies, to resist very strong private interests, for example, of the tobacco industry, of the food industry, and so on. And they can get the strength from a global regulation. We have a good example. This is not fantascientific. WHO promoted and obtained a convention on tobacco control, which is working, I think with good results. Going through one of the most strongest lobbies in the world, which is the tobacco lobbies. Why? Because we all recognize, why was it possible? Because we all recognize that tobacco is harmful to health. I would avoid production, but you cannot do it. I mean, there is also, this would be the ideal, do not produce harm. But there may be a traditional use of tobacco. There may be a nice, living good relation by smoking, but not as a market force. So at that point, you need a global regulation because this empowers weaker institutions to take action and regulate also at national level.
So after the panel, Eduardo and I will smoke a cohiba out in the... the next question, please. Yes, exactly.
Well, thanks. My name is David Rodriguez. I write for the newspaper Hispanovision, and I study economics at the Humboldt University here in Berlin. Yes, my question is related to this principal agent problem. You were telling us that it's important to regulate this market or this topic of the health, but how concrete would you do, or what kind of suggestion would you do? And I also would like to illustrate the case of the health insurance in Colombia, where everywhere was the whole insurances were privatized, and at the end they were spending the money for oil palm plantations, which doesn't have anything to do with the health of the people, and at the same time the hospitals were asking for their money, and they didn't become nothing because these insurances didn't have nothing. And this topic was published, everything, and until now there wasn't an answer by the government, or I don't know. So I would like to know what concrete suggestions would you do?
I mean, clearly a struggle, I think, what you pointed out. I mean, when governments are well-intentioned to enter into this type of public-private relationships and the according regulation, but are struggling with the capacity to deliver. I think you have a lot of experience in that in Africa, but also beyond. Kama, how do we reconcile this? You mentioned, yes, regulation, but not too much, and the correct one. How do we deal with the low capacity of countries to do that?
I think that one of the biggest problems we have in the discussion of the participation of the private sector or the public sector in health is to see health as one single block that has to be delivered by one person, and it's either or. There's a lot of sub-activities within the delivery system, even the regulatory system, that can be contracted out to the most efficient. Look at one area, pharmaceutical supply chain. Yes, government can buy all the vehicles and employ everybody that's there, or it can subcontract it out to somebody who will deliver it. In my continent, we have one colonial legacy of something they call the central medical stores. Anybody who's coming from our countries knows about it. Each one of you coming from the developed countries here, your governments are spending money every year reconstructing central medical stores. And I've never seen a successful one. And you don't have it in your own country. Why do you load us with it? It just doesn't work. It's a place for corruption. So what we ought to look at here is that the implementation of a good intention is quite different if you're looking at success. What you're giving as an example in Colombia is a well-intended thing, but there is corruption in it. And corruption does not spare the health sector. In fact, in my own estimation in my continent, the two most corrupt sectors or offices in Africa are, number one, the military, and I think that's universal. Two, the office of the president. And three is the Ministry of Health in the procurement of pharmaceuticals. Let's see what we can contract out. We've talked about the area of communication, the one commercial investment in Africa that has made a big difference to Africans and brought equity, even in elections, is a cell phone. We liberalized it. The cell phone is now there for everybody, and it's even making our elections and rigging of it much more difficult, and is opening new boundaries on how we can deliver health services and inform the poorest woman that she's supposed to come for pap smear and so on. These are the thinking out of the box things that we should look at. We could condemn those cell phone companies that they are commercial, they are making profit, but let us also be realistic about this. So this is the kind of dialogue that we are having in Africa right now, and I believe is the right one.
The next question, please.
Hello, everybody. I'm Dr. Salima. I work as a consultant for the Ministry of Health in India. Now, it's more of a comment than a question. First of all, to take on the arguments on regulation, just to take it a step forward, I think governments should not enter into public-private partnerships without building their own capacity to actually get into public-private partnerships, which is to a large extent being addressed. But I think there should be some kind of capacity building very strongly, because we can't speak of a forum like this without really speaking of capacity building of governments to actually get into public-private partnerships. My second observation is that if a government doesn't have a long-term plan, I mean, for example, we spoke of getting into a partnership because health service delivery is not good in the public sector. Fair enough, you are not having good delivery in the public sector, so you're going for a private sector. But for how long? Are you going to continue that? You should not enter into a partnership unless and until you know the road forward. For example, India has actually entered into a lot of ambulance services partnerships, as you might be aware. But now we are introducing the 102, which is the national ambulance service, I mean, in which we are expecting governments to procure. Now we are in a, I mean, it is a big question for us, how do we actually bring both together? So I think we should have a strategy very clear before going into any kind of public-private partnership as to where it's going to go. And thirdly, sir, to your comment, I think there are good models of drugstores and procurement systems in India. The Tamil Nadu model works fantastically well, the Tamil Nadu Medical Services Development Corporation, and I'm sure a lot of governments can learn from that one. Thank you.
Thank you. Now, Marie-Paul, the WHO promotes in many documents public-private partnerships, right? And you have reiterated that. But what the colleague from the audience just mentioned, what's the threshold of capacity? It's easy to say it should happen and it would be good, but how do we advise governments to build the capacity, and when do we know that that capacity is there? And are we prepared, we, international agencies, WHO, bilaterals, are we prepared to help countries? Or are we, as Eduardo says, I mean, we are happy to supply sexy support through, disease control programs because we can go back to our parliaments and say we have saved so many million lives. And building capacity is kind of a thankless, long-term, tiring, and sometimes very unsuccessful job.
Yes, of course. And but this is nevertheless the only way out on the high side. Otherwise, we're just continuing as we are doing it now. So the words these days, as the world has less finances, financial crisis, everything, are accountability and effectiveness. And these are the value that must be promoted. Accountability of the policymakers. Yes, we can say, and I have repeated several times, that the public sector the governments should regulate, but then the governments should be accountable. They are not there, even if the private sector is more effective in delivering services, it should be trusted to deliver the services, but also it should then be monitored so that everybody is accountable. So more accountability, which is capacity building for the policymakers, and also making sure that they are monitored and that they're just not given free rein to leave it and keep the public sector being inefficient.
Do we have another question? Sure. In the meanwhile, if there's somebody with a question, please identify yourself. There's another opportunity for a question from the audience. If not, Eduardo.
I just want to add on this, because it may appear that I'm against or believe the global or public-private partnership in general should never be the case. No, I'm not saying this. I think the public sector and private sector have and should collaborate, but there is a responsibility which is always public, and so governance must be very much strong in public institutions. This is the first issue. When it comes to WHO has engaged in many partnerships, and this has been an ideologically driven situation. We could not forget there is a neoliberal wave which brings that private is important and public must collaborate with private. This is something that's documented in literature. So the issue is, okay, let's take it as a positive, but we need to somebody has to be the gatekeeper, and this must be WHO. WHO has engaged, for example, in the Global Fund to control AIDS, malaria, and tuberculosis with no vote. So immediately said, I remain outside. I'm almost an observer. Yes, I participate in the board and discussion, including I provide staff, and have no advantage. Up to the point that in 2009, the Global Fund has to find its own identity, and today it's a Swiss foundation. The WHO is hosting a number of partnerships, which bring more trouble and burden to WHO of what they on what they give to WHO, increasing their capacity to lead worldwide. So there is a problem how we make the partnerships. It's not about partnering with the private sector.
That would almost be an extra panel and, of course, a can of worms, but we will not go there today. We are very good in time. I'd like to thank the panelists for that discipline. We now come to Tom, who has distilled the nuggets, the gold nuggets from this conversation. So please, Tom, the floor is yours for a quick summary.
Okay, I'm going to do my very best to get through this very quickly. It was an extremely rich discussion. Thank you very much. We started out assessing the importance of clearly defining the boundaries and the terms that we're using in terms of universal health coverage, which relates not only to the access to services, but also making these services high quality and providing protection from falling into poverty due to out-of-pocket payments. Now, universal health coverage can only be a means to an end, and that end is being improved health status, which is dependent on many other factors as well, including the social determinants of health. For the private sector, a more inclusive definition was discussed in terms of the use of non-state actors, which includes the full range of for-profit, non-profit, faith-based village doctors, all the way down to traditional healers. The role of the private sector, we know, has been overlooked due to poor awareness of its potential and lack of capacity among governments to engage effectively. So there's a great deal of mistrust between the two. But universal health coverage, the achievement of which is dependent on the role of the private sector being acknowledged and addressed as an equal partner. This is because the private sector has some comparative advantages in generating resources in terms of their R&D, and their freedom to experiment and innovate, but primarily because of its reach into communities where government cannot reach. So clarity around these definitions was important to challenge the ideological divisions that continue to plague this argument. And Karma's example of the treatment given to the pregnant woman in Kampala shows the reality of people using all kinds of public and private services on a daily basis. It does not matter to them whether it's a private or a public service. It matters that they're getting the right treatment. Now, regulation was a hot topic in this discussion. Lack of government regulation of the private sector is seen to be a problem, reinforced by the lack of data on the quality and the scope of services being provided. Governments were suggested to be the rightful stewards of their citizens' health, but not necessarily the implementers. Health is not a marketable good. It is a basic human right, so the market should not be left to its own devices, where profit-making is the main driver. Legal, regulatory, financial, and ethical frameworks are needed to create an enabling environment that will allow the private sector to contribute effectively. But we need to be realistic about the private sector. We need to regulate institutions that focus on making profits by selling harmful products and creating markets that deepen the problem of health. They are creating, for example, I think was said, an idea of health that is based on the consumption of drugs rather than well-being. So we should perhaps not forget that clean drinking water will have a far greater impact on improving a community's health than setting up a number of private clinics. Enforcement of that regulation is also another issue. Universal health coverage can be enshrined in a constitution, but the reality is often very different for many patients who must pay bribes and informal payments at the point of service, which is why financial protection is really important, e.g. health insurance schemes or patient subsidies, critical to stopping those patients, such as the woman in Kampala, falling deeper into poverty. There is a lot of progress happening in this area. The African Union mandated 2 years ago that every African country must start a social health insurance scheme. And it is still debated whether this could be public or private, but the consensus seems to be that the public must lead, but that the private should play a role. The system must be equitable and pro-poor, and there needs to be risk-sharing arrangements to cover the diversity of patient needs. Access to finance for private investment is equally important, and Karma discussed some of the big problems in Africa where the interest rates are exorbitant and prevent many private state actors from serving the poor. So where does this leave us for the future? Future priorities. There's still a lot of discussion around the idea of health, what is within and outside this sector, and that obviously has implications for the definitions of universal health coverage that we talked about earlier. The diversity of healthcare services is such that it seems to demand an equally diverse group of actors to deliver it effectively. So on the one hand, we have the back-to-basic approach that we heard from Eduardo, moving beyond the trend towards medicalizing the health system and providing funding towards specific diseases to focus on a broader definition of health that starts with primary health care and addresses basic needs such as shelter, water, and food. These should be the priorities if we want to focus on the life of the individual and not just the survival of the patient. At the same time, we need to develop greater sophistication in our health systems in order to respond to patterns of how the burden of diseases are changing. And this requires capacity building among both public and private actors. What this means is that the way in which we design and regulate also has to change, which includes regulating the production and marketing of products that are detrimental to health. Governments simply imposing frameworks on their own does not seem to have worked because the private sector was not at the decision-making table and has little incentive to comply, just as the government often has no capacity to enforce. So, concluding comment, all actors, whether public or non-state, need to work together at both country and global levels to create a more efficient market or health ecosystem. The suggestion was made that organizations such as the WHO could extend their partnerships and alliance with civil society and the sections of the private sector that are specifically devoted to the public good. But at the heart of this system should be the patient. We need to create a more informed patient population and build their capacity to evaluate and select the services appropriate for them. So I'll stop there. Please join me in thanking the German Federal Ministry and all of the speakers for today's session.
Thank you very much, Tom, for this excellent summary. I'd like, before we leave, just say a special thank you to Annette Bremer from GIZ and to Claire Carris from the bank, who helped with the logistics and the background and the speakers and everything that goes into such a session. I'd like to thank you, the audience, for, at this late stage of the summit, to stick with us. Thank you very much, and I hope you have taken some nuggets of Tom's with you. Obviously, in many ways, this discussion only has, touched the surface of a much deeper debate. But I thought it was a lot of food for thought for many of us. So thanks again for your participation, and thanks to the panelists for participating as well.